TOG 2024 Issue 3. The use of psychotropic medication in the perinatal period. Introduction. Pregnancy is not protective against mental illness, and 10 to 20% of women will experience a mental health problem antenatally or in the first year postpartum. Psychotropic medication is a core component of psychiatric treatment, often used in conjunction with psychological and psychosocial interventions. No psychotropic medication has UK marketing authorization for pregnant or breastfeeding individuals. Nevertheless, most are compatible with use in the perinatal period, with a few notable exceptions. General principles for managing psychiatric medication around pregnancy are summarized in Box 1. Number 1. Preconception planning is key. Aim for conception at a time of mental health stability. 2. Counseling must be individualized. Consider previous illness severity, medication response, comorbidities, and level of social functioning. A drug which has previously worked may be preferable to one with more safety data but unknown efficacy. 3. Refer to the appropriate team. Women with a history of severe mental illness should be under a specialist perinatal mental health team. They should create a detailed, individualized care plan and distribute this widely. 4. Maximize non-pharmacological interventions. Improve access to psychotherapy, social support, and occupational therapies. 5. Discuss risks pragmatically. Contextualize medication risks using absolute risk rates. Present these alongside the risks of untreated mental illness. 6. Timing of exposure matters. First trimester exposure may increase risk of congenital anomalies. Second trimester exposure may be associated with neurodevelopmental effects. Third trimester exposure may influence fetal growth or cause neonatal side effects. 7. Do not stop medication suddenly. If the decision is made to discontinue a psychotropic, it should be tapered gradually. Sudden discontinuation does not remove risks of exposure and may lead to relapse. 8. Avoid subtherapeutic doses of medication. This exposes the mother and fetus to both medication and untreated mental illness. 9. Use a collaborative, multidisciplinary approach. Minimize miscommunication and resolve differences in professional opinion. Receiving conflicting advice from different clinicians can lead to mistrust and anxiety. 10. Breastfeeding should almost always be encouraged. Most psychotropic medication is compatible with breastfeeding. Discarding breast milk or adjusting feeding times based on drug administration is not supported by evidence. Risks of untreated mental illness. Any consideration of the benefits and harms of psychotropic medication in the perinatal period must take into account the risks associated with untreated mental illness. Psychiatric illness is a leading cause of maternal mortality and has been identified as part of the wider constellation of biases that contribute to poor obstetric and neonatal outcomes. Some patients choose to discontinue psychiatric medication when trying to conceive, with limited recognition that this could be associated with antenatal and postnatal relapse. Some psychiatric disorders are specifically associated with increased risk of self-harm, which can be intentional or indirect, through chaotic or risk-taking behavior. Disorders which present with self-neglect, poor motivation, or executive dysfunction may be a barrier to healthy lifestyle measures, and rates of smoking, poor diet, and substance misuse are higher in people with untreated mental illness. Late booking and poor engagement with antenatal care may also contribute to worse obstetric outcomes. Untreated psychiatric illness has been associated with preterm birth, growth restriction, and developmental problems in the offspring, and there is growing evidence that maternal mental state may directly influence fetal development through epigenetic pathways. In the postnatal period, risks to the newborn must also be considered. Most people with mental illness do not harm their children. However, untreated or undertreated mental illness can have implications for the infant's safety and their cognitive, social, and emotional development. Challenges and limitations of the available evidence. Most randomized controlled trials exclude pregnant or breastfeeding women, and clinical recommendations are often extrapolated from medication use in the general population. Evidence on perinatal use of psychotropic medication is primarily derived from observational data in pregnancy registries, the quality of which is variable. Failure to adequately adjust for confounders can lead to misleading associations between medication and adverse perinatal outcomes. Comorbid risk factors such as obesity and substance misuse have been increasingly implicated in the etiology of pregnancy complications which had previously been ascribed to psychotropic medication. Observational studies often do not account for the severity and type of psychiatric illness, and few studies have compared women with untreated perinatal illness to women taking psychotropics. Evidence for the use of psychotropic medication in breastfeeding poses additional challenges. Associations with neonatal complications have almost exclusively been extrapolated from case reports or case series, and there is limited high-level evidence to guide best practice. As with congenital malformations, neonatal outcomes are subject to publication bias and rare complications are more likely to be reported than healthy outcomes. Studies of breastfed infants are often confounded by antenatal exposure to the same drug, and available evidence may not directly apply to situations in which medication is commenced postnatally. Additionally, clinical recommendations usually refer to healthy infants born at term. Caution is required when applying the evidence to breastfed babies who were born preterm or who have complex needs. Antidepressants. Antidepressants are a group of medications used to treat depressive and anxiety disorders including major depression, generalized anxiety disorder, post-traumatic stress disorder, and obsessive-compulsive disorder. They are widely prescribed and often initiated in primary care. Depression and anxiety are common in the perinatal period, affecting around 12% of women antenatally and 15 to 20% postnatally. Many pregnant women will either be using or considering the use of antidepressant medication and may turn to maternity staff for medication advice at a vulnerable time. Existing guidelines advise against routine discontinuation of antidepressants in pregnancy and recommend individualized risk-benefit assessments. Despite this, there is significant variation in clinician confidence with antidepressant prescribing, with up to 47% advising discontinuation if pregnancy is confirmed. It is imperative that treatment decisions are based on a critical understanding of the existing literature, rather than clinician inexperience or anxiety surrounding medication safety. Table 1 summarizes the major classes of antidepressants in clinical use. Selective serotonin reuptake inhibitors, SSRIs, have the largest evidence base for reproductive safety, meaning these are often the preferred choice. While less data exists for other antidepressant classes, none are absolutely contraindicated in the perinatal period. SSRIs, for example fluoxetine, sertraline, citalopram. There is risk of discontinuation symptoms and relapse if stopped abruptly, so do not discontinue suddenly. There is possible association with cardiac malformations, so recommendations are routine ultrasound screening, FASP, and consider fetal echocardiogram if taking paroxetine. There is risk of poor neonatal adaptation syndrome in up to 30%. So reassure, symptoms mild and self-limiting in most. Insufficient evidence to recommend medication reduction or discontinuation close to delivery. Risk of persistent pulmonary hypertension of the newborn in up to 3 in 1,000, so close liaison with neonatal team if coexisting fetal concerns like growth restriction and prematurity. There is possible association with postpartum hemorrhage, so active management of the third stage of labor is recommended. There is association with lower breastfeeding rates, therefore provide additional breastfeeding support. Serotonin and noradrenaline reuptake inhibitors SNRIs, for example duloxetine and venlafaxine. There is association with poor neonatal adaptation syndrome and persistent pulmonary hypertension of the newborn. So reassure, there is dose-dependent association with hypertension, with possible increased risk of preeclampsia, therefore perform close BP monitoring, and consider low-dose aspirin if coexisting moderate risk factor for preeclampsia like obesity. Noradrenaline and specific serotonergic antidepressants like mirtazapine have risk of weight gain, may increase risk of gestational diabetes. So monitor antenatal weight gain and consider OGTT with or without home blood glucose monitoring. Tricyclic antidepressants, for example amitriptyline and nortriptyline, have risk of anticholinergic side effects like constipation, urinary retention, dizziness. So stimulant laxatives recommended and do not remove indwelling catheters prematurely. There is narrow therapeutic window, thus significant risk of toxicity in overdose. So in women presenting with tremors or confusion, suspect toxicity and perform ECG. Selective serotonin reuptake inhibitors. Teratogenicity. No congenital abnormalities have been consistently associated with in utero SSRI exposure. Older studies reported various associations between SSRI use and fetal malformations, but these were limited by reporting bias and methodological flaws. Particular concerns existed for paroxetine, which appeared to increase the rate of cardiac defects to 2%, from a background rate of 1%. Larger, more methodologically robust studies which have adjusted for depression-associated confounders, have since failed to identify a significant increase in the risk of cardiac malformations. While pooled evidence still suggests a possible association between first trimester SSRI exposure and cardiovascular malformations, this is likely driven by confounders, including depression itself. The overall consensus is that if an increased risk of congenital malformations does exist, it is likely to be small in the context of antidepressant monotherapy. Pregnancy outcomes. Antidepressant exposure is not associated with an increased risk of miscarriage, stillbirth, or neonatal death. Meta-analyses have identified a small increased risk of preterm birth with antidepressant use, independent of baseline level of depression. This is unlikely to have clinical significance, however, as the reduction in gestational age at delivery associated with antidepressant exposure is approximately 3 days. Similarly, while antidepressant use in pregnancy has been associated with an increased risk of low birth weight, this equates to an absolute risk of exposed infants being 74 grams lighter at birth than matched controls. Serotonergic drugs impair platelet aggregation and are associated with increased bleeding risk. SSRI use in the final month of pregnancy is associated with increased risk of postpartum hemorrhage, although the heterogeneity of studies and lack of data on the severity of bleeding means that the magnitude of the risk is unclear. The potential effect on platelet function should be considered in the context of individual patient risk factors for bleeding or thrombotic events. There is no evidence to suggest that neonatal bleeding risk is affected by SSRIs. Neonatal and developmental problems. Poor neonatal adaptation syndrome is seen in 10% of all newborns and in up to 30% of those exposed to antidepressant medication. PNAS can present with a range of symptoms including irritability, jitteriness, feeding or sleeping difficulties. In the majority of cases, these symptoms are mild and self-limiting to a few days. PNAS may be more clinically relevant if there has been exposure to multiple psychotropic drugs, and in pregnancies complicated by growth restriction, prematurity, or congenital anomaly. The relationship between SSRI use and PNAS is not thought to be dose-dependent, and dose reduction at the end of pregnancy does not improve neonatal symptoms. Tapering or discontinuing antidepressants close to term is therefore not usually recommended, particularly as this is a time of vulnerability to psychiatric deterioration. Serotonergic antidepressant exposure is also associated with persistent pulmonary hypertension of the newborn, in which pulmonary vascular resistance fails to decrease at birth, leading to hypoxia. While PPHN is associated with serious neonatal morbidity, the absolute risk associated with antidepressant use is smaller than previously suggested. Incidence is increased from 2 in 1,000 in the general population to 3 in 1,000 in infants exposed to antidepressants, and this difference may not be significant when adjusting for confounders. Antidepressant exposure in pregnancy is not associated with an increased risk of autism or childhood behavioral problems, however there is growing evidence that untreated maternal depression may increase these risks. Breastfeeding. Most antidepressants can be used safely in breastfeeding. Transient adverse effects such as colic or drowsiness have been reported, however longitudinal studies have not identified any neurodevelopmental concerns. Sertraline is associated with the lowest excretion in breast milk and is often the medication of choice in antidepressant-naive women. If there has been a previous positive response to a different antidepressant, however, continuing or reinstating this agent is usually recommended. This cohort of women may need more support to establish breastfeeding. Serotonin and noradrenaline reuptake inhibitors. Studies which have adequately controlled for confounders have not found an association between serotonin and noradrenaline reuptake inhibitor exposure and congenital abnormalities. Both duloxetine and venlafaxine are associated with a dose-dependent risk of hypertension, and their use in pregnancy has been associated with an increased risk of preeclampsia. While there are no guidelines specifically addressing preeclampsia risk in pregnant women taking SNRIs, it would be prudent to facilitate home blood pressure monitoring, and low-dose aspirin should be considered if there are coexisting moderate risk factors. The use of SNRIs in the third trimester has also been associated with PNAS and a small increased risk of PPHN. The limited evidence on the use of venlafaxine and duloxetine in breastfeeding is reassuring. Noradrenaline and specific serotonergic antidepressants. The most commonly used noradrenaline and specific serotonergic antidepressant is mirtazapine, which has additional benefits as an antiemetic and appetite stimulant. It has been used successfully in the management of hyperemesis gravidarum. Exposure in pregnancy is not associated with major congenital abnormalities or pregnancy loss. Mirtazapine is associated with weight gain and insulin resistance, and use in pregnancy may increase the risk of gestational diabetes. It has not been associated with adverse effects in breastfed infants, although its sedating effects may be a barrier to nighttime feeding. Tricyclic antidepressants. Tricyclic antidepressant use is relatively uncommon due to their anticholinergic effects and risk of cardiotoxicity in overdose. TCAs may be helpful, however, in cases of comorbid chronic pain. There is no evidence that TCAs increase the risk of congenital malformations. There may be a higher risk of PNAS with third trimester TCA exposure than with serotonergic antidepressants, and TCA use in breastfeeding has been associated with neonatal sedation. Mood stabilisers. Mood stabilisers are used in bipolar and schizoaffective disorders, which are both associated with high rates of perinatal relapse. Other indications include recurrent depression, behavioral disturbances in people with intellectual disabilities, and puerperal psychosis. Off-license prescriptions are sometimes used to treat affective instability in patients with complex trauma and personality disorders. The available data on several mood stabilizers is primarily derived from their use in epilepsy, which is independently associated with adverse obstetric outcomes and is often a study confounder. Caution is advised when applying these findings to other patient populations. Recommendations for the use of mood stabilizers are summarized in Table 2. Lithium. There is 2% risk of cardiac malformations. So fetal echocardiogram at 18 to 22 weeks gestation is recommended. There is risk of maternal diabetes insipidus with risk of fetal polyuria and polyhydramnios. Therefore perform serial scans for fetal growth and liquor volume in the third trimester. Lithium is renally excreted with a narrow therapeutic window, so there is risk of maternal and neonatal toxicity. Therefore avoid nephrotoxic medication and recommend delivery in hospital. Also measure lithium levels monthly until 36 weeks, then weekly until delivery. If changes to fluid balance, for example preeclampsia, hyperemesis, lithium can interact with neuromuscular blocking agents, so anesthetic pre-assessment in the third trimester is recommended. Lithium has high transfer into breast milk, so breastfeeding is not recommended due to risk of neonatal toxicity. Sodium valproate has 10% risk of major congenital abnormalities and 30 to 40% risk of neurodevelopmental disorders. So do not abruptly discontinue, and urgent psychiatric review to consider alternative treatment regimen. Multidisciplinary counseling including discussion of termination of pregnancy. If the pregnancy is managed expectantly, then prescribe high-dose folic acid. Also ultrasound screening under a fetal medicine unit. There is a theoretical risk of hepatotoxicity in breastfed infants, therefore breastfeeding is possible as there is minimal excretion in breast milk. However, monitor for neonatal jaundice or bruising or bleeding. Carbamazepine is associated with dose-dependent increased risk of major congenital abnormalities. So prescribe high-dose folic acid preconception and throughout the first trimester. Also ultrasound screening under a fetal medicine unit. Carbamazepine is an enzyme inducer which can interfere with vitamin K-dependent clotting pathways and combined hormonal contraception or progestogen-only pills. Therefore, it is recommended to perform active management of the third stage of labor and give intramuscular vitamin K to the newborn. Also, offer alternative methods of postnatal contraception. Lamotrigine has high transfer into breast milk, however, breastfeeding is generally safe, but monitor for neonatal toxicity, for example rash. Estrogen-containing contraception can decrease lamotrigine levels, leading to increased risk of mental health relapse. So, offer alternative methods of postnatal contraception. Lithium. Lithium is highly effective in treating mania, mixed affective and depressive episodes. It is also used for long-term relapse prevention and is known to reduce the incidence of attempted and completed suicide. Lithium diffuses freely across the placenta and concentrations are equilibrated between maternal and fetal circulations. This means that use in pregnancy results in considerable fetal exposure. Teratogenicity. While early studies found an association between first trimester lithium exposure and Epstein's anomaly, this finding was largely driven by reporting bias and confounding. Subsequent studies have confirmed a small increase in the risk of cardiac defects, 2 per 100 births compared with 1 per 100 in the general population. However, rates of Epstein's anomaly were comparable to background rates in the general population. Pregnancy outcomes. Women who continue lithium in pregnancy have comparable rates of complications to women who discontinue lithium prior to pregnancy. A possible association between lithium exposure and increased fetal growth has been reported. Lithium can cause nephrogenic diabetes insipidus in the mother, resulting in fetal polyuria and polyhydramnios. For these reasons, fetal growth and liquor volume monitoring is recommended. Monitoring. Lithium has a narrow therapeutic window. Serum levels less than 0.6 millimoles per liter are subtherapeutic in most individuals but will still expose the pregnancy to the risks described above. Lithium toxicity develops at levels greater than 1.2 millimoles per liter, with potentially fatal cardiotoxicity and neurotoxicity at levels greater than 2.0 millimoles per liter. Serum levels should be monitored throughout the perinatal period and should be taken 12 hours post-dose. Lithium is excreted unchanged by the kidney. With increasing gestation, plasma volume expansion and increased glomerular filtration rate will reduce lithium concentration and higher doses will be required to maintain a therapeutic level. Serum levels are highly sensitive to changes in renal function or fluid balance, so hyperemesis gravidarum, urinary tract infections or preeclampsia may precipitate lithium toxicity. Careful monitoring is essential in the intrapartum and early postpartum period, when rapid changes in fluid balance coincide with a high risk of psychiatric relapse. Hospital delivery is recommended to facilitate intrapartum fluid management and monitoring of serum lithium levels, neonatal complications, and the mother's mental state. Peripartum lithium management is summarized in Figure 1. Figure 1. Peripartum lithium management. If a pregnant patient presents in spontaneous labor, then withhold lithium at the onset of labor. If a cesarean section or induction of labor is planned, withhold lithium 24 to 48 hours beforehand. Then 12 hours after last dose, check bloods for renal function and lithium level. On the blood form, include the time of the last dose and the time the sample was taken. If there is evidence of renal impairment or lithium levels more than 1 millimole per liter, then withhold lithium, maintain hydration, and repeat bloods every 12 to 24 hours. If after initial or repeat bloods the renal functions are normal and lithium levels are less than 1 millimole per liter, then restart lithium after delivery at the pre-pregnancy dose. Once lithium is restarted, repeat lithium level and renal function after 5 days and then twice weekly until levels have stabilized. Signs of lithium toxicity are weakness, abnormal movements, confusion, hypotension, hypothermia, tachycardia, and seizures. Neonatal considerations. Lithium exposure is associated with low APGAR scores, lethargy, and feeding difficulties, resulting in an increased rate of neonatal admission. Delivery should take place in a unit with the expertise to identify and manage neonatal lithium toxicity. Breastfeeding. Current guidelines advise that breastfeeding is contraindicated in mothers taking lithium due to the risk of neonatal toxicity. There is emerging evidence, however, that term infants can be breastfed or mixed-fed safely. Cabergoline should not be given to suppress lactation as it can precipitate mania or psychosis. This applies to other circumstances in which breastfeeding is contraindicated and there is increased risk of psychotic illness in the mother. Sodium valproate. Sodium valproate is highly teratogenic and is contraindicated in anyone of childbearing potential. Use in pregnancy is associated with a 10% risk of neural tube and other congenital malformations, and a 30 to 40% risk of neurodevelopmental disorders. In exceptional circumstances in which there is no suitable alternative, valproate may be used in women of childbearing age but strictly within the terms of the pregnancy prevention program, informed written consent, highly effective contraception, and yearly specialist reviews. If someone becomes pregnant while taking valproate, they must be referred for urgent psychiatric review and should be advised against abrupt discontinuation, as this can lead to rapid deterioration. In most circumstances, an alternative medication will be offered and valproate will be tapered. High-dose folic acid is not protective against major congenital anomalies, but supplementation is recommended to reduce the risk of neural tube defects associated with low folate. Ultrasound screening should take place within a fetal medicine service, and a multidisciplinary, individualized care plan must be written and distributed to all relevant clinicians. Sodium valproate can be compatible with breastfeeding, but monitoring for neonatal hepatotoxicity is advised. If the woman chooses to terminate the pregnancy, this would meet criteria under Clause E of the Abortion Act. In this vulnerable cohort, this decision may occur at late gestations, and it is essential that women are referred to services with the expertise to offer choice of abortion method, in line with international guidance. Carbamazepine. Early pregnancy exposure to carbamazepine is associated with a dose-dependent increased risk of major congenital abnormalities, particularly neural tube defects. The rate of malformation in low-dose monotherapy, less than or equal to 700 mg per day, is 4.5%, compared to a background risk of 2 to 3% in the general population. Supplementation with high-dose folic acid preconception and throughout the first trimester is recommended in women taking carbamazepine, as this may reduce the incidence of fetal malformation. Current evidence does not support an association between carbamazepine exposure and adverse neurodevelopmental outcomes, however intelligence quotient may be higher in children exposed to periconceptional folate. Carbamazepine is an enzyme inducer and can interfere with clotting pathways. While the risk of postpartum hemorrhage in exposed mothers may be marginally increased, current guidance does not recommend oral vitamin K supplementation. Intramuscular vitamin K at birth is recommended to prevent hemorrhagic disease of the newborn. Women taking carbamazepine postnatally should be encouraged to breastfeed, as transfer into breast milk is minimal and exposure does not adversely affect infant growth or development. Carbamazepine interferes with the efficacy of combined hormonal contraception and progestogen-only pills, so women who are not exclusively breastfeeding should be offered alternative postnatal contraception. Lamotrigine. The risk of congenital malformation in pregnancies exposed to lamotrigine monotherapy does not differ significantly from the background risk, and limited evidence does not support an association with adverse neurodevelopmental outcomes. The combined effects of hemodilution and increased drug clearance result in lamotrigine levels falling significantly in pregnancy. Lamotrigine prescribed for psychiatric indications is commonly titrated based on clinical presentation, and there is a lack of consensus on the role of serum lamotrigine monitoring in pregnancy. Therapeutic drug monitoring is not routinely performed antenatally but may be clinically valuable, particularly where there are concerns about compliance or in the presence of comorbidities such as renal failure. Following delivery, pharmacokinetic parameters return to preconception levels very rapidly, and women who have required an increased dose in pregnancy should have this reduced promptly postnatally. Failure to do so is associated with lamotrigine toxicity, which may present as serious cutaneous reactions including Stevens-Johnson syndrome. Lamotrigine levels in breastfed infants reach approximately 30% of maternal serum levels. However, breastfeeding during lamotrigine monotherapy is mostly considered safe. Skin rashes have been reported in infants exposed to lamotrigine through breast milk, and close monitoring for toxicity is required, particularly following dose increases in the mother. Estrogen-containing contraception is known to decrease serum lamotrigine levels, reducing its effectiveness. Alternative postnatal contraception should be offered. Antipsychotics. Antipsychotics are used to treat psychotic disorders including schizophrenia. They are also used in the treatment of bipolar disorder and treatment-resistant depression, and some are used for rapid tranquilization, see Figure 2. Most antipsychotics fall into one of two groups: first-generation antipsychotics, FGAs, and second-generation antipsychotics, SGAs. FGAs are associated with anticholinergic side effects and extrapyramidal side effects, EPSEs, such as dystonia, rigidity, and tremor. SGAs tend to cause less severe neuromuscular side effects, however they are more likely to cause weight gain and insulin resistance. For women who are taking an antipsychotic prior to conception, this would usually be continued during pregnancy. There is increasing evidence of safety in the perinatal period, and discontinuation is associated with relapse, self-neglect, and suicide. Recommendations for the use of antipsychotics are summarized in Table 3. Long-acting depot injections are sometimes used in patients who prefer this or who have a higher risk of non-adherence. Depot formulations are not associated with increased risks compared with oral antipsychotics. Teratogenicity. Studies which have controlled for confounders have found no increase in congenital malformations in pregnancies exposed to FGAs or SGA. Pregnancy outcomes. Women with long-standing psychotic illness are more likely to be obese, smoke or have chronic hypertension or diabetes. Addressing these comorbidities, ideally preconception, is likely to have a greater impact on pregnancy outcome than any risk associated with antipsychotic medication alone. Antipsychotics do not increase the risk of miscarriage or stillbirth. While some studies have reported an association with small for gestational age or low birth weight, these risks are not significantly higher in women taking antipsychotics than in unmedicated individuals with psychotic illnesses. Long-term use of SGAs is associated with metabolic syndrome, increasing the risk of obesity, diabetes, and hypertension. Two specific SGAs, olanzapine and quetiapine, increase the risk of developing gestational diabetes mellitus compared with women who discontinue their medication preconception. For other agents, the rate of GDM does not differ significantly from the rate in women with psychotic illnesses who remain unmedicated during pregnancy. Independent of GDM diagnosis, SGAs have been associated with increased risk of fetal macrosomia. Current guidelines do not make any specific recommendations regarding GDM screening in this cohort. A pragmatic approach would be to offer all women on SGAs a 28-week glucose tolerance test, OGTT, with consideration given to an earlier OGTT and/or home blood glucose monitoring to women with coexisting risk factors. Neonatal and developmental problems. Antipsychotic use in pregnancy is not associated with neurodevelopmental problems in the offspring. Exposure to antipsychotic medication in late pregnancy may be associated with neonatal extrapyramidal side effects including restlessness, dystonia, and tremor. Infants exposed to clozapine in utero should be monitored for the risk of agranulocytosis for the first 6 months of life. Breastfeeding. Antipsychotics are excreted in breast milk in small amounts, and most agents have not been associated with serious neonatal adverse effects. Breastfeeding is contraindicated in patients taking clozapine due to the risk of neonatal agranulocytosis. Most antipsychotics are associated with hyperprolactinemia and will not interfere with lactation, with the exception of aripiprazole, which can lower serum prolactin in a dose-related manner. Women taking antipsychotics other than clozapine should be supported to breastfeed if they wish to, while being mindful that night feeding and significant sleep disruption may increase the risk of relapse. Figure 2. The use of antipsychotic medication for tranquilization in the peripartum period. If a woman displays violent or aggressive behavior which poses risk to themselves or others, then inform liaison psychiatry, senior obstetrician, and midwife in charge. Initially offer non-pharmacological de-escalation. Then pharmacological therapy. Offer oral medication before parenteral administration. Aim for monotherapy where possible. Lorazepam dose, 1 to 2 mg. Maximum 4 mg in 24 hours, combined oral or IM. It is the first choice benzodiazepine with rapid onset, it is short-acting, has low placental transfer. Do not co-administer lorazepam with intramuscular olanzapine due to risk of fatal drug interactions. Third trimester use is associated with risk of floppy baby syndrome and neonatal withdrawal. Promethazine dose, 25 to 50 mg, maximum 100 mg in 24 hours, combined oral or IM. Promethazine is generally safe and well tolerated, so often preferred as first-line agent. Haloperidol dose, 2 to 5 mg. Maximum 20 mg in 24 hours, combined oral or IM. Pre-treatment ECG is recommended. Avoid haloperidol if QT prolongation or cardiac disease. Third trimester use is associated with risk of poor neonatal adaptation syndrome and neonatal extrapyramidal side effects. Olanzapine dose, 5 to 10 mg. Maximum 20 mg in 24 hours, combined oral or IM. Do not co-administer it with intramuscular benzodiazepines due to risk of fatal drug interactions. Olanzapine can cause brief rise in heart rate and blood pressure. Third trimester use is associated with risk of poor neonatal adaptation syndrome. Aripiprazole dose, 9.75 mg, maximum 30 mg in 24 hours, combined oral or IM. It is non-sedating. Third trimester use is associated with risk of poor neonatal adaptation syndrome. Haloperidol, olanzapine, and aripiprazole antipsychotics are preferred when agitation is driven by mania or psychosis. Only one antipsychotic should be used. Consult with liaison psychiatry if maximum dose of antipsychotic monotherapy is not effective. Table 3. Antipsychotics. First-generation antipsychotics FGAs, for example haloperidol, zuclopenthixyl, flupentixyl. All FGAs and some SGAs can cause hyperprolactinemia, thus increase risk of subfertility. Therefore, measure prolactin levels if trying to conceive. Dose-related adverse effects of FGAs. Extrapyramidal such as dystonia and tremor. Anticholinergic effects like constipation and dry mouth. Cardiovascular effects, for example arrhythmias and orthostatic hypertension. Neuroleptic effects such as malignant syndrome, which is rare but fatal. It is recommended to perform immediate assessment with support from psychiatry and intensive care teams if patient has either hypothermia or muscle rigidity or autonomic dysfunction. FGAs are associated with risk of neonatal extrapyramidal side effects. Therefore, monitor newborns for abnormal movements or sedation. There is low transfer into breast milk for most FGAs and SGAs, so encourage breastfeeding, unless on clozapine. Second-generation antipsychotics SGAs, for example olanzapine, quetiapine, risperidone, and clozapine, are associated with extrapyramidal, anticholinergic, and cardiovascular side effects, however they are less common than with FGAs. Recommendations are same as in FGAs. SGAs cause an increased risk of gestational diabetes and fetal macrosomia, particularly olanzapine and quetiapine. So it is recommended to monitor for excessive weight gain, offer OGTT with or without home blood glucose monitoring, and serial growth scans. Clozapine is reserved for treatment-resistant schizophrenia due to significant side effects such as risk of agranulocytosis, myocarditis, severe constipation, paralytic ileus, and hypersalivation. Monitor full blood count as per clozapine clinic surveillance schedule. Offer stimulant laxatives and avoid opiates. Also, monitor for postoperative ileus following cesarean section. And monitor newborns for agranulocytosis if exposed in utero. Advise against breastfeeding. Sedatives. Sedatives are central nervous system depressants used to treat anxiety and sleep-related disorders. The most frequently prescribed sedatives include benzodiazepines and non-benzodiazepine sedative hypnotics, Z-drugs or Z-hypnotics. Some antihistamines can also be used for their sedative properties. Both anxiety and sleep disturbance are common in the perinatal period, and pharmacological treatment may be indicated in the short-term management of these conditions. A pragmatic approach for the use of these medications is summarized in Table 4. A word of caution: while changes in sleep quality and pattern are ubiquitous in pregnancy and postpartum, sleep disturbance may herald or precipitate severe mental illness. Women with significant insomnia should be assessed for signs of underlying psychiatric illness, particularly if this persists despite the use of hypnotic medication. Table 4. Sedatives. Benzodiazepines are either long-acting, with half-life of 20 to 200 hours, for example diazepam and clonazepam, or short-acting, with half-life less than 20 hours, like lorazepam and temazepam. Benzodiazepines are associated with tolerance and/or dependence with long-term use. So, do not discontinue them suddenly, due to increased risk of dangerous withdrawal symptoms. Benzodiazepines are associated with floppy baby syndrome and/or neonatal withdrawal if prolonged use in third trimester or given around the time of delivery. Therefore, consider tapering before delivery. With close collaboration with psychiatric team, patients may require inpatient admission. Benzodiazepines have minimal transfer into breast milk, so reassure, as intermittent use unlikely to cause neonatal problems. Lorazepam may be preferred. Also, monitor for neonatal sedation, particularly if there is prematurity or complex needs, or significant exposure antenatally or intrapartum. Z-hypnotics, for example zolpidem and zopiclone, have possible association with small for gestational age and low birth weight, so serial growth scans are recommended if prolonged use or polypharmacy. Z-hypnotics increase risk of neonatal sedation with prolonged antenatal use. However, they have shorter half-life than most benzodiazepines and are metabolized quickly by fetus. Therefore, reassure, as occasional use is unlikely to cause neonatal problems. Z-hypnotics have minimal transfer into breast milk, so monitor for neonatal sedation if prolonged use and reassure, as occasional use is safe in breastfed term infants. First-generation antihistamines, for example promethazine and diphenhydramine. Anticholinergic side effects are common, e.g. dry mouth, constipation, and urinary retention, so stimulant laxatives are recommended, and do not remove indwelling catheters prematurely. Can reduce prolactin secretion, causing impaired lactation in the early postpartum period. Therefore, consider alternative sedative if keen to breastfeed and reassure, as occasional use once breastfeeding is established will not affect lactation. Benzodiazepines. While initial studies reported an association between benzodiazepine exposure and oral clefts, larger studies have not demonstrated an elevated risk of congenital malformations. Recent epidemiological studies have also shown that benzodiazepine use in pregnancy is not associated with preterm birth, small for gestational age, or neurodevelopmental problems in the offspring. Prolonged use of benzodiazepines in the third trimester has been associated with poor neonatal adaptation, either through CNS depressant effects or through neonatal withdrawal. CNS effects can vary from mild sedation to aspiratory depression and hypotonia, floppy baby syndrome. Symptoms can vary depending on the dosage and half-life of the drug. Severe CNS depression can be rapidly reversed with flumazenil. Tapering from a long-acting to a shorter-acting benzodiazepine may reduce neonatal side effects while mitigating the risk of rebound anxiety and maternal or neonatal withdrawal. Benzodiazepines are excreted in breast milk in low concentrations. Lorazepam is often favored in lactating mothers owing to its shorter half-life and established safety profile. Breastfed infants should be monitored for sedation, particularly in the context of prematurity or polypharmacy. Co-sleeping should be discouraged in women taking any sedating medication, as this can increase the risk of sudden infant death. Z-hypnotics. First trimester exposure to zopiclone or zolpidem does not confer an increased risk of congenital malformations. Zolpidem use in pregnancy has been associated with low birth weight and small for gestational age, but a large sibling-matched analysis has not supported this. After adjusting for confounders, Z-hypnotic use in pregnancy is not associated with preterm birth or adverse neurodevelopmental outcomes. Zolpidem is the best-studied agent in breastfeeding and has not been linked to adverse neonatal effects. Antihistamines. First-generation antihistamines are widely used in pregnancy and are available over the counter. Whilst they can be used for their sedative properties, most safety evidence in the perinatal period is derived from studies of their use in nausea and vomiting. Antihistamine exposure is not associated with congenital malformations, and most of the available literature does not support a relationship with adverse obstetric outcomes. Occasional use of diphenhydramine or promethazine is considered safe in breastfeeding, but infants should be observed for excess sedation if use is prolonged. Antihistamines can lower basal prolactin secretion and interfere with breastfeeding initiation, however they do not affect lactation once it is established. Conclusion. Large, well-designed studies increasingly demonstrate that most psychotropic medications are compatible with use in the perinatal period. Conversely, untreated mental illness carries significant risks for both mother and baby. Receiving inconsistent advice from different clinicians can lead to anxiety and suboptimal adherence to treatment, exposing the pregnancy to both medication and untreated psychiatric illness. Individualized risk-benefit discussions are essential and should be led by multidisciplinary teams with the skills and experience to provide holistic care. Several evidence-based resources are available to guide these decisions and support maternity teams in providing comprehensive, informed, and compassionate care. In the end, here are the solved CPD and SBA questions of the TOG. Kindly pause to read.